right. Hi, everyone, and welcome to part two of our four-part digital event series, Confronting a Pandemic, jointly developed and delivered by STAT and Harvard Medical School. Thanks for being here. I'm Erin Broadwin, health tech correspondent at STAT, and in just a moment, I'll be joined by my co-moderator and our featured speakers to talk about telemedicine during the COVID-19 pandemic. But before we begin, just a few quick housekeeping items to go over. So at the bottom of your screen, you should see a few icons. There's a chat icon and a Q&A icon. You're going to use the chat feature to chat amongst yourselves or to send a message directly to the STAT team. That's me. If you find you're having any technical difficulties, just tell us in the chat. Don't put your questions for us in the chat. If you do have a question that you'd like to ask one of our speakers, please use the Q&A feature to type your question over to us, and we will try to answer it live. Again, we won't be taking questions from the chat, so please type your questions into the Q&A. I'd now like to welcome my co-moderator, Stanley Shaw, Associate Dean for Executive Education at Harvard Medical School, along with our two featured speakers, John Glazer, President of the American Telemedicine Association, and Lee Schwam, Vice President of Virtual Care at Partners Healthcare Digital Health. Welcome, everyone, and I'll pass it to you, Stanley, for a quick intro.
Thank you, Erin, and welcome to everybody. So as hospitals scrambled to prepare for COVID-19 and people retreated to their homes, the adoption of telemedicine to replace in-person doctor visits has skyrocketed. We've all seen the headlines. Changes in reimbursement, licensure, and regulations soon follow. Today, we'll explore what these changes mean for the future of telemedicine. And our panelists bring wonderful experience from the front lines of patient care all the way to the national and global policy and reimbursement conversations. Dr. Lee Schwam, a pioneer in using telemedicine to care for stroke patients, has led Mass General Brigham through its battlefield scale-up of telemedicine during the current crisis. And John Glazer has set health IT strategy as a senior executive at Health Systems, Siemens Healthcare, and Cerner, and is now president of the American Telemedicine Association. So let's get started. Welcome, Lee and John. Thank you for joining us. To start, could you help us go beyond the headlines about this burst of adoption and start to help us think through how does the field move forward from here? And I'll ask both Lee and John to answer from their perspectives.
John, why don't you go first, and I'm happy to follow in your footsteps.
Yeah, fair enough. Well, I'll say some stuff, and Lee will correct me and point out where I strayed from the facts or made stuff up. I think the burst is the right word, Stan. It went from, almost overnight, in a matter of days, frankly, for a number of institutions, from almost no telehealth volume to incredible telehealth volumes, et cetera. And not only in terms of the sort of patient-provider interaction, but also providers who were quarantined, taking care of patients from home, or family members visiting people in the hospital because of concerns about contagion, or the workforce being scattered all over Kingdom Come. So it exploded in a multifaceted way. And I think, what happened along with that is a lot of rules and regulations and reimbursement practices were relaxed, and using the language of CMS waived. So HIPAA regulations were waived. A lot of the state licensure barriers were waived. A lot of the location, you had to be here in order to qualify for a legit telehealth visit, were waived. And so all these things were withdrawn and say, go take care of it. We got a crisis here, et cetera. So now going forward, and a lot of this waiver is in place for as long as, quote, the crisis lasts. And it's a good question about what does that mean? Who declares it's over, at what point? And particularly if you say, golly, it's going to be over when a vaccine arrives. Geez, we could be here for another year plus, 2 years perhaps. But as while that has been done, it grew so fast that a lot of what was done is chaotic, unsustainable. A lot of non-integration workflow practices, probably some visits shouldn't have been telehealth that were. People weren't showing up at all for their doctor who should have shown up, et cetera. So now is the time, progressively, and then Lito, is where as a sort of community, those who provide care, those who finance care, those who are involved in government, those who represent the patient and consumers, come back together and say, what do we want it to be? We've undone it. Now let's redo it in a way that reflects the fact that it's here to stay here. And that conversation has really just started.
Well, I should just parenthetically say that, I cut my teeth on telehealth when John was the CIO of my health system. And so we've known each other for a very long time. I agree with everything that John said. And I think just to put a little bit of a slightly different spin on it, we responded to a crisis and came up with a lot of innovative solutions with existing hardware, existing software, really recombining tools that were available and making like a bunch of new recipes. We took all the food that was in the cabinet in the refrigerator and we just started cooking with it. But some of the recipes worked pretty well and we'd want to cook them again. Some were pretty tasteless and we wouldn't want to go back to them. None of them are hardened, right? None of them are bulletproof. None of them are idiot proof. There's a lot of shaky legs on some of these products. And so if we were doing this from scratch and we had a normal implementation plan, we would have piloted at small scale, we would have tested, we would have hardened, and we would have rolled it out, and we would have had a 2-year plan. And that's actually pretty much what we had, was a 2-year implementation plan in our health system, 11,000 physician and MDs, NPs, and APPs, and then probably another 5 to 10,000 other kinds of providers. We didn't have that luxury. So now what we have to do is we have to look at this crop of new products and services we have, and we have to say, that thing that we did, we want that long term. Christ, COVID or no COVID, that's a really important innovation in care delivery. I need to harden that. I need to stand that up. I need to scale that out and support it. And I would say some have referred to this as technical debt. We've incurred a sizable debt of the projects we would have worked on that had to get put aside while we worked on COVID. And then there's a tail to all this work of support and infrastructure and maintenance and equipment and supplies that we've accumulated. We're going to have to factor that in if we're going to continue that work. That can only happen with the right economic model. If we don't have reimbursement for this work and we don't have some way to fund the capital expense of all this equipment, this work really can't continue effectively. There will be other things that we say, this is really important. This needs to be mothballed and be ready to be popped up at a moment's notice if we get into another surge. Like the Army Corps of Engineers, they can build a bridge in, 3 days out of, parts that they assemble in modular fashion. And they keep those things stockpiled in case you need to build a bridge instantly, but that's not a permanent bridge. And then I think the last thing is we really have to say, okay, we did this as an emergency, but there's clearly a convenience factor, a cost savings factor, and a patient experience factor here that's really valuable to patients. And once they've tasted this new way of getting care, many of them will not want to go back to the old way of doing things when appropriate. So we're going to need to define clinical appropriateness around a lot of these interventions so that we have guiding principles about, how should it be documented? How should it be billed? What's the appropriate reimbursement? What's the right patient, the right technology to support that work?
Great. So Lee, you're an academic who's studying this, but you also have a boots on the ground role. And John, you have a macro sense of the field at a national level. And I think both of you opened this discussion with a talk. You were talking about how some of the telemedicine laws have changed, specifically now that we are in an emergency situation, a pandemic. So I'd be curious to hear, and I think perhaps our audience would be too, what happens after clinicians start to change their workflows, patients start to change their habits, people get really accustomed to this new virtual care and telehealth focused type of medicine, and then the telemedicine laws revert. What happens then?
Yeah, I can start again. I don't think they'll quote revert. In an analogous way, it's for a lot of people who are, white collar office jobs, et cetera, are now working from home. When this is over, will they all go back to the office just like they did before? I doubt it. I mean, there'll be some mixture, of return, but also virtual work because there's upside to all this stuff. So I don't know that we're going to go back to the sort of old way that we do things. I think there's some scaffolding that needs to be fixed. So integration with the EHR was not really done. A lot of the workflow not really done to go through. I think there are doctors who say, boy, I hope I'm doing the right clinical care over telehealth. I don't really know. And so I've got to go ahead and sort of guide people about when it's appropriate to be face-to-face and when is it not appropriate to be face-to-face. And we got a lot of consumers who aren't just not seeking care at all. We got to get them back saying you really do need to come in to see your doctor. Now, some of these might be tough. So anyway, a lot of it's got nothing to do with rules and regulations. It's got to do with practice and the way things are done and cement them in a thoughtful and a more binding and durable way here. And I think the rules and regulations will revert back, but it's unclear to what. So to what degree will licensure revert back to the way that it was? I don't know that that's clear. And to what degree will location work back? I think it is a complicated conversation because you have the federal government who obviously weighs in because Medicare pays, both Medicare regular and Medicare Advantage. They have HIPAA, they govern privacy and security, and they actually have some licensure dealing, and they oversee a lot of narcotics laws that surround this stuff. But you combine that with 50 states who also have their version, a group insurance commission that oversees, group health insurance within the state. The state medical societies regulate the licensure laws that go, along the way here. And the states also determine Medicaid policies, et cetera. And then you have the private insurers, the Aetnas and the Cignas, et cetera. But then you have self-insured employers. So all of these folks have to come together along with professional societies. So if you were to turn to a particular specialty society like Lee's, for example, although they tend to be fairly well developed there, what are the right practice guidelines here that should be going on here, et cetera? So I think there is a multifaceted conversation that needs to occur to bring all of the pieces and the parties together to settle on the regulations. It's hard to know. It won't revert back, but what will it become is not clear. And I don't think it's a simple answer either. I don't think it's as simple as saying, well, we ought to pay everybody. Well, that's not quite right either. It's got to be a little bit more balanced than that. I mean, one thing, just Aaron, then I'll shut up here, is if you look at, say, before COVID struck, the number of outpatient visits nationally were X. And then it struck, and that dropped dramatically, but telehealth filled in the void, but it didn't replace it. So the total telehealth and face-to-face was still well below X that was going on here because people were afraid to come in. So it's not just a question of paying this sort of substitute visit. We actually have to change the visit dynamic that is going on here about some visits shouldn't have been happening, some should be and need to continue. So anyway, it's a lot of parties that are involved in all this kind of stuff. And the world is different. It's not like sort of changing regulation back to the old way care was delivered or the old volumes, et cetera. We actually have a new reality here of practice that has got to be accommodated.
Yeah, I think John's said a lot of important things that are very forward thinking. And I think I'm going to take a slightly more pessimistic answer to your question to start with, which is that I think John is right. We need a new conversation. I think I think practice has moved on past regulation, but the straight facts are that when those quote unquote COVID emergency period is ended in each state, all of those waivers were tied to that state of emergency and they will expire. So the fact that anyone could practice in the state of Massachusetts without a license, as long as they were duly licensed in another state, that waiver is pegged to the state of emergency. And when that is resolved, unless the governor takes new executive action, that will stop. Now, does that mean providers will stop providing care across state lines? I don't think so. I think patients will be demanding it. I think providers will feel compelled to continue to do what is in good faith in the best interest of their patients. But it's a little bit more than jaywalking and less than felony, but we're going to have a situation that we've created now where there's an expectation of care delivery that is in violation of many of the existing statutes. Yeah. So I do think that action will need to happen relatively quickly in order to fill that void and start to enable that conversation. What I'd like to see would be extensions of those waivers through government action for a period of time until such time as all restrictions around travel and capacity in medical centers have been restored. So when we go back to seeing patients in the office, I mean, I think John alluded to, well, when people start seeing patients in the office again, will we just, will the payers say, okay, we pay for in-person, you need to be seen, go be seen in person. We can't bring in the numbers of patients into our offices that we did before. Until we have a vaccine or very effective treatment, our waiting rooms will probably have to accommodate half or a third of the number of people who used to be in them. The packed waiting room is a thing of the past. So I think we're going to be in a really awkward space where we all have to take an approach of really restricting liability around practices that are not in the best interests of patients, right? When people are being rogue actors and are willfully violating the law for their own gain, we need a different stance than when providers and health systems are trying to do the best to care for the patients in the circumstances we now face. CVS and Aetna released an interesting report just the last couple of days. I didn't read the whole report, but I read the headline, which is basically claims for chronic care conditions are way down. There's an impending wave of medical complications that are going to happen If the diabetics aren't seeing their diabetes doctors, if the heart failure patients aren't seeing their heart failure doctors, if the COPD patients aren't seeing their pulmonary doctors, because we know those conditions require really thoughtful and continuous management. So I think we have enormous pent-up demand of medical care that has not been met during this crisis. We probably have some care that was more, I would say, nominal, deferrable, readily deferrable, elective or intermittent care that could easily be spaced out. But we're way too far on the other end of that pendulum. We have a giant, the snake has to swallow an elephant now. We got to figure out a way to process that surge of routine non-COVID care that's been building up in demand while we've been so focused on saving lives from COVID.
Yeah.
Yeah, I think, Aaron, just a little bit, Lee is correct. There's a wall in there that basically says someone declares, either at the federal or the state levels, it's over, and all of a sudden this stuff snaps back to where it was before. It's like, say, all of a sudden we're going to go back to the era before electricity. And all of a sudden there we are in an era without electricity. So there is a wall, and it's kind of hard to know where that wall is, but it isn't infinite. And maybe the right thing to do is to extend this. I do think we're getting into the time now, and that's not to imply that the crisis is over, but a lot of the ramp up to handle it is sort of in play. You know, maybe we're flattening the curve, et cetera. But I know from the American Telemedicine Association perspective, the last couple of weeks have been full of, well, golly, we've got all these providers going from 0 to 60. How do we get them or help them go from 0 to 60? Lee's been doing it for a while, but most of the industry has not. And they just didn't know what to do. So just basic, how to survive and to do, you know, the core correctly or as well as you can. And that's largely, now's the time to shift from the immediate crisis of ramping up on telehealth to begin to shift to the longer term conversation. And so the ATA has begun to reach out to, you know, other groups within the healthcare. It's going to be a multi-stakeholder task. It says, let's come together, work with the feds, work with the states to begin to craft this agenda. You know, if it's going to snap back to what? Becomes the conversation that's got to occur. So anyway, we're right on the edge of where it's the time to begin to have that discussion.
The other thing that I want to bring up, Aaron, and I think we were going to talk about it later, but it feels like the time to talk about it is now, is when we think about what happened with this radical shift. Before COVID, telehealth was something that you did if it interested you. It wasn't mandatory because you always had the option of going in person. So who were the people who were embracing it? They were generally wealthier, they were generally English speaking, they were generally Caucasian, and they had, they had an iPhone or some other device readily at their disposal, and they have broadband Wi-Fi at home, and very not a diverse, equitable kind of representation of the population in the United States. With COVID, telehealth filled the void for all those people who couldn't get care by walking in. But what it did inadvertently is increase the risk of depriving access to people who have social determinants of health that put them at risk, who could previously walk in to the city hospital and get their care, walk into the community health center, get their care. Now we've said, you can't come here in person.
Right.
And if they don't have the device, they don't speak the language, they don't have the digital or the health literacy, now we've actually distanced them further from care. And that was why the Medicare decisions around paying for phone-only visits was so important. So it didn't bake into the system a sort of systematic bias against those individuals.
Right.
But we have a long way to go toward understanding how to embrace that community, help them understand how to access this care successfully, and to begin to introduce this sort of digital upscaling that John's been referring to across the whole population.
Right.
It can't just be in chunks here and there. It has to be spread smoothly over the whole population.
Yeah, I'm so glad you brought that up, Lee, because that is something important and it's something that's been on my mind. The fact that, there are people for whom right now the virtual care as it's being practiced just simply will not work. I mean, people without internet access, people in rural communities, people who can't be seen at home, live with roommates, have certain forms of mental illness, people dealing with domestic violence at home.
Yeah.
So that is a really, really important point and something that I think.
Yeah, and this is an issue that I've been thinking about for a long time. We've done some work looking at whether there are systematic approaches that reduce the vulnerability of patients with limited English proficiency. We published a paper about stroke care and how systematic approaches to stroke care tend to be blind to things like English proficiency or level of insurance and such, because when you're hospital based and that patient arrives, at that point, your systems really should kick in. we should really be thinking about some of the institutions in our communities that need repurposing. And one of the things that comes to mind are like public libraries, right? We've got libraries all over the cities of our country. Very few people are coming in reading books anymore. They've been digitally upscaling for a while to accommodate kind of a new form of civic purpose. Maybe they become the equivalent of the Minute Clinic, where communities have free access to high quality broadband, telemedicine equipment, and your doctor's visit is in the public library. I think we need to rethink our public spaces,
Right.
the way that we provide access to utilities like the internet, and really have a new conversation about broadband as a right and not broadband as a luxury.
So can I
Yeah, I
ask,
think that's
let me just pick up on that thread,
Sure.
right? So we've had many questions about what you miss by a remote visit, namely kind of the measurements, the phenotyping, the vital signs, right? And if you talk about some of the disparities that COVID has revealed, there's the medical aspect of the comorbidities, like hypertension, high blood pressure, or heart failure. And those you really do benefit from a blood pressure measurement, you benefit from a physical exam, right? And so there are these solutions out there. A LiveCore now can do a 6-lead EKG. There's lots of sensors that could give vital signs. But it also relates to this problem we just talked about in terms of unequal access to some of these tools. And so how can we think about folding in more measurements so that remote visits really can have a fuller sense of replacement of the actual visit?
Yeah, no, this is a great question. And let me just talk about this for a few minutes from a few different dimensions. Number one, I think to date, with rare exception, sensors are consumer grade, unvalidated instruments that have been purchased either by health systems and given to free for patients, or are largely in the sort of Fitbit, Apple Watch category. You buy it, it's cool. Hey, I can send some stuff on it. Very few have been subject to medical grade validation. So they're not, we don't have the architecture for ubiquitous monitoring. The second thing I would say that you've brought up here is this concept that this 2x2 grid, or these 3x3 grids of, this is an ambulatory virtual visit, this is a remote patient monitoring, this is an, e-consult. Those are false dichotomies. These things are really merging and blending. We should think about them as individual tools in the toolbox, and they're going to blend and hybridize. So you're wearing your Apple Watch, it detects an arrhythmia, it sends an e-visit note to your doctor, who then turns that into an e-consult. The cardiologist says, I need to actually see that patient in person, so you do a video visit. They determine you have a serious arrhythmia, you come in the office for a procedure. Like that should be one healthcare event. We should think about that as one encounter, not 17 different transactions. So the last thing that I'll say about this is that I think we really need to reconceptualize what the visit is. We've taken 15 different things and stuffed them into what we call visit. Insurance verification, identity verification, laboratory testing, vital signs monitoring. We can disaggregate those activities, and in some ways might even be better that by the time I see you on the video, I already know your blood pressure, I know your blood test results, I know what your pulmonary function tests show, and now we're going to discuss it all together and come to an answer. So I would argue that 80 to 90% of all visits have some component that is really about focused face-to-face attention between provider and patient. Some visits, it's 90% of the visit. Some visits, it's 10%. But almost every visit has that component. So some visits easily lend themselves to telemedicine encounters or these other kind of virtual encounters. Some really don't that well. You have a mole that needs to come off. You got to go into the office and have the procedure. It's very hard to imagine how you're going to avoid that. But the conversation about risks and benefits, the consent, all that stuff could have been done in a disaggregated manner. We have just valued the time and attention of the team to be centric. It's centric for the team. You come in to my house and I make you do 7 things you could have done in any other way, but you do them now and you do them here because it's what works for me. Truly patient-centered care is you have a shopping cart in Amazon You go on in the morning and you pick, groceries. You go on in the afternoon and you pick sunglasses, and then you order a dishwasher, and then you hit pay, right? You assemble the transaction and then execute. There's no reason why a patient-centered medical care wouldn't allow you to assemble those pieces in a time and a manner that's convenient for you, and then assemble them for the encounter where the doctor has to look at them, or quite frankly, be pre-processed by artificial intelligence, and then make sure the doctor is as prepared as possible. So I can see sparks going off in John's head as I talk about all this stuff. Let me pause.
No, it's great. The energy, I love it. I love it. I think a couple of things. One is you could have this approach to the time that's coming before us and say, listen, what we got to do is shore up the scaffolding that's kind of rickety. We made certain things, we got to make sure it doesn't collapse. The reimbursements that cause the collapse, bad practices cause the collapse, et cetera. We're just going to shore it up, et cetera. That's not wrong, but it's insufficient. You say, no, actually, there's a time here and an opportunity to really rethink a bunch of stuff that we've done, as along the lines that Lee has done. This is a good time to do it. What's always striking to me is when, an industry changes, it's usually because an external shock causes it to change, and it can be the web came in and shocked retail into what was going on. Or in the 70s, the oil crisis came in and shocked us into more sustainability and more fuel-efficient cars here. A long time in healthcare, particularly in this country, the quote shock has been value-based care, the slow grinding movement to, pay for performance versus pay for volume here, et cetera. It may be that COVID is the shock that causes or will cause us to sort of re-examine in a way that is much more dramatic, perhaps more even effective than this slow but sure, and it doesn't say let's stop doing the value-based care thing, but this may be the precipitating event which challenged all aspects of the system. Nobody emerged unscathed in all this type of activity here, to rethink a lot of what we've done here. And I think part of our thinking, above and beyond remembering every now and then, and I'm a CIO, so I get to say this, is every now and then we get these sort of technical fascinations, advanced states of technical arousal. We get all worked up by all those gizmos you can buy and attach to yourself, et cetera. I do think sometimes we can learn a lot from developing countries which have been incredibly low-tech, with lower skilled people who actually do a pretty darn good job of getting out to very far-flung parts of their country and delivering pretty good care. So anyway, as we go through it, sure, it doesn't mean to rule out the sort of sophisticated technology, but let's learn from a lot of different sources, including sources that are global and in fact, in some ways, not as advanced, but in some ways more advanced than we are.
Can I just add one more comment that I think John triggered for me is the other part of this crisis that has been so challenging from an information support perspective is that we went from very curated devices inside the hospital, inside the practices, with lots of hands-on to configure, and a restricted set of patient devices that could meet and greet on the other end to, 1,000 flowers. Any device, any bandwidth, even this video conference, right? We're each in a different location. We each have different bandwidth constraints. We're each on different devices. You had almost no control over what device. It's BYOD, right? Bring your own device. That's the world we live in right now. That limits us dramatically. I think as we think about that scaffolding, we need a very nuanced and layered approach to this that meets the interaction where the devices are. So some stuff is really very appropriate for being conducted on a smartphone. Other stuff is not. So we really have to also think about what are the minimum device requirements and the minimum software requirements for any one of these interchanges. And that's even separate. That's just the technical layer, never mind the security layer and the privacy layer. With Zoom becoming so ubiquitous, obviously the malicious attacks on Zoom become ubiquitous. And for our patients, if we just turn it around again and say, our patients see probably on average of 4 or 5 or 6 different providers in our health system and probably others outside our health system. What if each provider is using a different platform? That patient now is being bombarded by 7 different pieces of software. They have to download all these things. Then they get malicious invitations to join meetings with people that aren't really healthcare providers. Like, we got to tighten that channel up and really make a secure and safe conduit, which is our electronic health record, as the place in which these interactions should be occurring. We need a chaperone around this for the benefit of our patients.
Yeah. So since we've spent a little bit of time talking about devices and technology, I want to take this moment to take a question from the audience, which I think is a good and important one. Which technologies do you see as most important, perhaps, in enabling telehealth in the future? Particularly, this person asked, ones that are not widely used just yet. And this question is from Harry Bickerstaff.
I'll take a crack at that, and I
Go
think
ahead.
John will have maybe a different perspective. I think short lens, we need incredibly stable, really robust collaboration software like this that's very stable at low bandwidth. That's vital, because that is the lowest common denominator. It's got to perform well at low bandwidth, and it has to be multi-device agnostic. So it can't restrict you to an iPhone, iOS device, or, I would argue, even in this country, it's iOS and Android, but in other countries, there are many other, there are other software platforms, particularly in China. So the platform really needs to be ubiquitous. I think the second thing I would say is that we're just started to dip our toe into augmented reality and virtual reality, sort of AR and VR. And again, if you look back in time, we always dip our toe in something first for a while, and then it becomes more mainstream. I think that augmented reality is going to play an important role in medical care in the future. Probably when we have 5G ubiquitously available, so that we really have really high bandwidth and high reliability, and the opportunity for many simultaneous connections, so we don't overwhelm a particular access point. But I think the whole concept of telementoring, of performing or assisting a robotic surgical procedure, of providing guidance on site to our trainees in medicine, of guiding patients through how to navigate both their own healthcare, the use of specific devices, syringes, needles, pumps, whatever. I think we're like just at the beginning of that. And if you think for a minute about video conferencing, 3 months ago, every platform looked pretty much the same. It's pretty much low quality bandwidth, low quality video, standard background, no frills, no features. If you wanted to have something pretty behind you like Stan does, you needed to have a green screen and special software. And within 3 months, you can put a custom background for Zoom, and you can make little animated videos behind you and entertain your friends. I mean, that scale of innovation, pretty extraordinary. Think about how that could be applied for medical education, for patient education. So I think we haven't even dipped our toe in the water yet when it comes to how this work could be applied in the future if this becomes an important avenue for care delivery. Now, John will bring us back down from the clouds.
I don't know about that. But I think, Aaron, it's a fair question. And I think one of the things you did sort of, if you go back over the last 50 years of IT and its use in society and in business, you find that the really profound IT innovations sort of altered the world were a collection of technologies that came together along with a business model at the same time. So if you look at the sort of iPhone mobile device, it's a combination of the form factor of the iPhone itself. It's a combination of battery life. It's a combination of the ecosystem for apps, that went along the line here. And it was a combination of sort of a business model that sold it. If you look at the personal computer, is the Intel SET, along with DOS from Microsoft, along with IBM that mass manufactured, along with VisiCalc, along with Ethernet. So anyway, these things come together because a category comes together and coalesces into a sort of a unified whole in a way. So I think to Lee's point, and you could add, well, the advances in sensors and a variety of things that will have to come together in order to make this happen. Are some more important than others? Sure, in particular situations, some are quite foundational. But nonetheless, there's no single technology or class of technology that will cause this to be, the next generation, be multiple things coming together.
Okay.
I really like that. I especially love the reference to VisiCalc, which is a phrase I haven't thought about.
There you go, Lee. We're of the
like
generation. Remember that. Stan maybe too.
No, but I think John is right. And I would argue actually, without the App Store, we wouldn't have the iPhone. It was really the concept of creating a distribution economy where the device could become a platform and could transform. I mean, even if you think about the sheer brilliance of the idea that this thing has no dedicated buttons on it, what that created, the ability to create a graphical interface that could be customized to whatever need that particular software application had, it's almost like adding zero into the number system, right? It creates space for a dramatic repurposing of the device for almost any need that the software can configure. It's really moving to software as a service. And so I think there needs to be a service ecosystem, and it needs a financially viable model. And we don't have that yet, I think, in telehealth. We're getting much closer because we've now suddenly realized, ooh, there is a scenario where this is no longer nice to have. This is like, a backup generator in a hospital, right? You don't use it very often, but you must have it, and it must be able to go on at full speed when you need it without any warning, so you better test it frequently. I used a metaphor in a talk yesterday that this is sort of like the Army Reserve or the National Guard. You got to have telemedicine infrastructure. It's clear to me now. We can't ever be without it in the future, because anything that shuts us down and prevents us from moving means we have to continue to deliver vital services, and medical care is a vital service. So we got to reposition this and think about, I think, as John said, how do we build the ecosystem for true interoperability and understanding a set of rules and guidelines around what care can be turned into virtual, and how do we map that to a framework where there's an economy of there's consumers who need it, there are providers who can provide it, and there's something in the middle that makes that exchange possible.
So, I think Lee mentioned that without reimbursement, a lot of this just can't move forward. And so we have a couple of questions from Cynthia Flora and Saul about reimbursement, whether it's from CMS or private payers. And if I can just push you a little bit on what you think will happen, might we devolve to this dystopian state where you now have like prior authorization, like maybe telehealth won't be covered, but for certain people, you could say, well, they're very high risk to go to a hospital and maybe we'll cover it. Like what do you think will happen? What do you think may get pulled back?
Yeah, so I want to modify my comment about reimbursement to really frame it more like how John said. There has to be a sustainable economic model. That might not be reimbursement, right? I mean, it might be, you think about value-based care, it's not really reimbursement, it's really risk contracting. So I think we need some sustainable financial model that places value on that transaction or that capability and allows it to, allows what I said before, a consumer and a supplier meet in an encounter of some kind, whether it's brief, instantaneous, asynchronous, or long-term, and there's an exchange of activity, and there's a flow of funds. And that can be fee for service, that can be value-based, that could be in-app purchases. I mean, this could move, ironically, right? Telehealth could create a platform where patients can auction off their care to the lowest bidder. I mean, we have plenty of, Uber is a perfect model of, selecting vendors based on, a momentary transaction prices vary widely. That the economic model we have currently, I don't think is likely to change radically in the next, 2 to 3 years, but we are driving some of these decisions based on the model that we are currently in. It is not fundamentally the model we must have in order for healthcare to be delivered. It's the model we've inherited, and it's really hard to change that model, especially unpredictably. But I would say that we need there to be an understanding that this is an important mechanism for the managing of patients' health and managing through disease and chronic disease, and that it needs a sustainable financial component to make it viable. It's possible that other players could enter this space and actually contribute revenue to support that without necessarily being the rendering provider or the creator of the experience. The App Store takes a fee for letting you host your product in the App Store. They're not actually building your app, they're hosting. So I think there are opportunities to rethink how we finance healthcare, but telehealth, virtual care, we have to just start thinking about it as part of healthcare. And then we have to figure out how to pay for it like we pay for other things in healthcare.
Yeah, I think, Stan, there's a couple of aspects. One is there's an immediate problem of a lot of providers taking on the chin and in dire fiscal straits. So we got to deal with that, so the hospitals don't go south, individual physicians don't go south as a result of that. So that's a separate question. That's not necessarily the sort of sustain. It's just how do we keep people employed, frankly, and not from taking an unnecessary hit here. And the reimbursement question has been around for forever. It's been the old mantra that has gone on there. I think there are two things that are different now as we return to that conversation, whether it's some relaxation of fee-for-service boundaries or movement to value-based care. One of which is that there's experience at scale with this. Now you can actually talk from a reality. I tried it, we lived it, et cetera. This is what worked, and I found this okay. And so I think sometimes reimbursement, not that it wasn't real, but we hid behind it because of the discomfort or the who wants to make a change. I don't really get it. I'll feel incompetent or variety things like that. So one is this real working experience. The second is the consumer is saying, wait a minute. I'm still nervous about going in here and I actually like this type of thing here. So I'm going to enroll in, pick a regional health plan. You'd better have telehealth coverage. Because, it'll be a while till people are really comfortable with a lot of what we're going to go out to do. And a while they say, oh, what a pain in the ass driving in to see Lee was. I'd much rather talk to him like I am now, et cetera. So we'll see a consumer pull based on fear and based on convenience, which will sort of pull, some people who have not been pulled before into making more inroads or progress along this line.
Although, John, what I worry about there is, ironically, it's the reverse of what we usually worry. The people with the pull are the people in the commercial plans with wealth. So we might have a weird split where, unlike the usual, where Medicare and Medicaid lead and the commercials follow, we might actually see the commercial products offering this more ubiquitously, but Medicare and Medicaid, where you don't have a choice really about your plan, says, no, I'm not paying for it. I don't have the money. I'm not paying for it.
Yeah, no, fair enough. And it's an equity issue we'll have to deal with. Correct.
Yeah.
Okay, so moving slightly away from the reimbursement question, or potentially adding a small wrench to it, I want to talk a little bit about what the future of care, post-pandemic. I don't even know if it's fair to really use that term, but once the real calamitous aspects of this crisis kind of start to subside, one of the questions from the audience here, and this one is from Sophie Ehrlich, do you see a combination or a hybrid of both in-person appointments and telemedicine taking place in the coming, months, years?
No, no question. We were, just to give you an order of scale and magnitude, as John has alluded to, we were 0.8% of all ambulatory visits at Mass General and Partners Healthcare were virtual in January, February. Mm-hmm. In March, we went progressively from 0.8% into the early months of April to 80%. Now, total volume went way down, but virtual is basically all that's happening, except for, you have to have chemotherapy for your cancer treatment. You have to have emergency surgery for your gallbladder. We're not going to stay at 80%. First of all, there's a whole bunch of care that, as we said, needs to be done in person. There are a lot of people who still feel more comfortable coming in person. But I think gone are the days when most people have only in-person care. I just think, as John said, we've tasted that new, that new beverage, and we're not going to get rid of it quickly. I think that when I was asked to make projections about this at my hospital, I said, in 3 years, I think we should legitimately be doing 20% of all of our follow-up visits virtually. Not even new patients. I didn't even go there, just follow-ups, 20% across the board. We should be able to hit that target. Some people were very skeptical. I think no one is skeptical about that anymore. We've clearly found that 50% of our visits, if they have to, can be conducted with these virtual means. So 20%, I would bet, would be where the barometer would drop to in the what you're calling kind of post-COVID. I think the problem with this is, unlike a major winter storm or something, or a bombing that happens, there's a clear envelope, and that shape of the back of that envelope is sharp, and then we're back to wherever. I think that the problem is this COVID envelope is like spike, spike, spike. So I don't think we get to go to post-COVID quickly, which means we're going to have a year or more of evolution, which means we never get to post-COVID, because by the time we get to that place that you described, we're already different. We've already had to accommodate. Yeah. And I just don't see it ratcheting all the way back. I just think we're going to come up with a new way of thinking about this, just like banking. I was talking to a reporter the other day, and I said, when was the last time you went to the bank for cash? And she was like, never. I said, you remember bringing your passbook to the bank? And she said, what's a passbook? So for those of you who are under the age of 35 or 40, you used to bring like a passport looking book with you to the bank, and it had the amount of money you had in your account printed in it, and you pushed it to the teller, and they gave you $50, and they put -50, and they drew a new number, and they stamped it, and they gave it back to you. That's what we used to do. We wouldn't think of that as banking. We don't think of mobile banking as mobile. We think of it as banking. Right. So I think this is just going to become healthcare. This is just, I have an in-person visit, I have a procedure, I have a virtual visit, I have a prescription request. They're all just ways that we're going to be delivering healthcare. The question will be, who's going to decide when it's appropriate to do a visit. Are we going to have, like John alluded or Stan alluded to, pre-authorization? Do I have to get approval that I can do your psychotherapy over a virtual channel to get paid for it? Am I going to get paid the same amount for my physician service, but the technical component of the bill is going to be, half or zero what it would be in person? Mm-hmm. These are artifacts of our current reimbursement system, but they will drive a lot of decision making.
Mm-hmm.
So we have a question from Lisa. Is anyone you know of partnering up with CVS and local pharmacies so people can go to their pharmacy and have a telemed consult there? And to tie it to something we've alluded to a little bit is, what's the best way to blend remote services with some brick and mortar component, right? You mentioned libraries, obviously hospitals, but not just CVS, but Walmart, Amazon has Whole Food stores.
Well, the answer to Lisa is it's called Minute Clinic, and CVS is already doing it. So they have already recognized the value of trying to provide services in a service delivery location where you might also pick up collateral products as a result of the visit. You have a sore throat, you need throat lozenges. Well, you're already in CVS. Let me get your prescription filled here. Let me get my throat lozenges here. So several Minute Clinics have telemedicine capability. The Walmart model has built in these health clinic pods that they're building now, that they have telemedicine built as well. So urgent care, I think, is sort of another way to think about this, and virtual urgent care is also a big piece of consumer, direct-to-consumer telemedicine right now. I think what we have to realize is, if as academic health centers and integrated delivery networks, if we don't get this right and figure out how to plug this in, we will lose that piece of the market to fragmented, one-offs that will, I think, ultimately undermine our ability to be successful. We can't afford to give away the low-margin business. It's the Clay Christensen disruptive innovation model. You give away the primary care and the urgent care. Next, you give away the simple subspecialty care. Next thing you know, people can get all their care there. Why do they need to come to you at all?
I think, Stan, obviously with the virtual, you could be anywhere. And so you could be in a CVS, you could be in your garage. I mean, we have 60% of the employed adults in this country are hourly workers. So you got an hour for lunch and you can't afford to take time to go to the doctor. So you'll do it in your car if nothing else. Mm-hmm. And so we'll see all this sort of location invariant type of thing for all kinds of classes of care. So it will be in those now. And one of the things to recognize is the CVS and the Walgreens have a problem, and that Amazon and other retailers are eating their lunch on a lot of the stuff you buy there, vitamins, greeting cards, soap detergent, et cetera. And you've got gazillion stores. You've got this very expensive footprint that you've got to fill somehow. And so they're highly motivated to draw you in for your health care. I mean, because they want to fill you in, get your prescriptions and this, that, and the other. So they have very strong motives. They also have a whole lot of knowledge about how to deal with you and me as consumers. So I think as a health system, you got to be quite concerned about this very potent set of actors here who've got a lot of resources, highly motivated and highly skilled, coming in and doing exactly this. Now, to Lee's point, you can create more fragmentation, along the line here, and so we've got to be careful with what we have wrought.
Mm-hmm. Mm-hmm. Yeah, I mean, if we had true interoperability, which we do not have, of medical information, there is a way out of the fragmentation argument, and it's one of the reasons why some groups may be resistant to true, really truly liberated interoperability, because then that CVS transaction for your minute care could be incorporated into your medical record, and some of the arguments about the fragmentation go away. We're also, I think, sadly, a very long way away from true medical record interoperability, despite federal legislation to the contrary. I think that we got to figure out how to work together around this. I really do believe that effective partnerships between groups like pharmacy-based delivery of care and academic medical centers makes a lot of sense. We just have to figure out, again, the financial model. When you couple a delivery network like CVS with an insurer like Aetna, now you can see how there's a strong incentive there to rethink the relationship with the hospital. Because CVS owns you and owns the portal to your care, they're in a very different position to negotiate with you, as opposed to the hospital owns you and is your portal to care, and then can negotiate reduced prices on pharmacy benefits management, right? So a lot of this in the end becomes who can aggregate the medical demand, because we have a huge system in this country to pay for the medical services that are delivered. If healthcare were not centrally financed, if everyone just paid for care by themselves, like is true in some countries, you see a very different pressure on pricing. You see a very different model for acquiring care, and you see huge disparities. In my field, I'm a stroke neurologist, and we give treatment for acute stroke with a drug that in the US costs almost $7,000 or $8,000. In some countries, it costs $400 or $500, but there are many patients who don't request the treatment because they can't afford it.
Yeah. I do want to take one more question from the audience. Not to say that this will be our last, we might have time for one more, but from Kimberly Kafus, this is something that we didn't quite get to yet, so I want to make sure that I ask it. How satisfied are providers overall with virtual visits? Do they feel like they're providing care that's comparable to that provided in person?
So I would say that there's some overlap. It's a bit of a Venn diagram. There's some overlap. Certain things you do feel the same over virtual as they do over in person. There's some aspects to virtual care that are more rewarding. See a patient in their home. You meet their aging grandmother. You see them with their pet. You experience a component of their environment that you wouldn't otherwise see. You see the chaos, the quality of their environment. You see if they're living in poverty. I mean, there are pieces. This is a house call for many patients. As John alluded to, sometimes they'll call you from the office, from a restaurant, from a I've had visits in Dunkin' Donuts before. I mean, where people will go to find that place is interesting. But I think for our providers, it also turns out to be, in some ways, a refreshing change, because since the screen is between you and me, I've had patients say to me, doctor, when I see you in the office, you spend a lot of time going back and forth between me and the computer.
Right.
But when I see you in virtual, I see you face to face the whole time. And 90% of the visit is you and me, where 10% was me logging on and logging off. When I see you in person, you're like 10% of my visit. I got to get in my car. I got to drive downtown. I got to find a parking spot. I got to wait in the waiting room. Like, I only see you for a tiny portion. So I love this. And because the patient loves it, it's more of a rewarding experience for the physician. So I think it's a trade-off. There's some things that don't feel as good. You can't reach out and put your hand on someone's shoulder to comfort them if they're crying. You can't do the healing aspects of touch that relate to doing an examination, putting that blood pressure cuff on. There are opportunities for dialogue that you lose, but there are opportunities that you gain. John, have you had a virtual visit as a patient?
Yeah, and I thought it was fine. I went in for a series of lab tests, got on the phone with my doc, and she said, you're normal. And I said, that's debatable, but at least the lab values are okay. I think, Aaron, to the question, there's still having people get used to the right way to do this. And so part of the discomfort can be, I don't really feel right. And they're probably right that they're taking visits this way where they shouldn't, et cetera, or not really comfortable with it. So anyway, we have to calibrate sort of what's appropriate versus not appropriate, et cetera. The second, there are times of care which are purely transactional. I just want to know that I'm okay. That was sort of my physical. It's very transactional. I like my PCP a lot, but I don't, golly, it could have been a robot for all I care. In that particular. There are other types of care where it really is care at a very human level, in which there is something we got to talk about. It's highly emotional. It might be scary, this, that, or the other. And you say that really should be done face to face because we're human beings, at a level that's got to go on and get this kind of stuff here. I do think, but part of it is just, it's the newness. So all of us have been going through Zoom meetings versus the old face to face we used to do. And it just takes some getting used to. How do you do that? Yes, there's some loss, but certainly there's a convenience gain. But part of this is, and maybe I certainly remember in my early teens going out on dates for the first time and feeling like I, was about as incompetent as possible and as ungainly and et cetera. So there's an awkwardness that can be early as part of these things as we get used to the technology. So some of it is just lack of familiarity with the approach.
Got it.
So maybe my last question can look to the future in an aspirational way. So could I get you both to comment briefly on, the most promising new horizon that telemedicine might enable? So looking broadly beyond just replacing something, but I think as Lee and John both mentioned earlier, how might it liberate us to do things in a new way, not based on inertia or how we're paid or how we've always done it or the doctor's convenience, but liberate us to do things in a new way that better meet the needs of patients?
So I'll just say two quick things, because I know we're short on time. Number one, we move away from these periodic, randomly decided intervals of care, and we move much more toward a care when it's needed model, which liberates us in time and in space and makes it rational. Like, it makes much more sense to see a Parkinson's patient for 5 minutes, 17 times over the first month they're on a new medicine to get it right, 2-minute interactions, 17 times, than to see them once for 35 minutes on one dose of medicine, right? So there's some obvious ways that making it work for me as a patient in my life with my constraints would be ideal. I think the second thing is, Vivek Murthy, who was the former Surgeon General, has really highlighted a problem in our society of loneliness and social isolation. We see it magnified to, worldwide proportion with the pandemic, but forget pandemic, people are lonely. They're living, or even if they're surrounded by people, they're lonely. Loneliness leads to high rates of death from cardiovascular disease, from stroke. It's a chronic stress. It leads to mental illness. Boy, digital health, virtual care ought to be able to help us address the issue of loneliness in a really meaningful way that I think would be extraordinary. And it'll probably be a combination of human and machine AI-driven interventions. But we really have an opportunity here to tackle something that we've never been able to tackle before.
Yeah, Stan, quickly, my contribution to that would be essentially access. So it's access not only geographic and people far away, and maybe even nearby who just can't get to it, but just making it a lot easier and a lot less expensive to get to, care. But it's also access in a sort of a derivative of what Lee said, is rather than once a year getting my, engine checked, is to do that from time to time as appropriate. So it's much more bite-sized chunks. The access is not confined to this annual thing. And so anyway, it might be able to visit and decompose it in a way to a series of more modular interactions, which is better for lots of different reasons. So access of time and access of geography.
Great.
Yeah, like your warning light goes on in your car. It says you need an oil change. You go in for your oil change. That might be at 2,000 miles. It might be at 8,000 miles, as opposed to saying you must come in 6 months.
Correct.
All right. Well, thank you both. With that, I think we're about at time and unfortunately need to wrap things up. Thanks again to John and to Lee for joining us today, and to Harvard Medical School for working with STAT to produce these chats. Our next one in this series will be taking place next Thursday, May 21st, again at the same time, 1 p.m. EDT. The session will cover tech solutions for monitoring COVID-19 and contact tracing. So I hope you can join us. Thanks again, everyone. Stay safe, be well, stay 6 feet apart.
Okay. Aaron and Stan, thanks.
Bye, everybody.
You too, Lee.